Hey everyone, and welcome. Today we're going to dive into something super cool, the incredible ways our bodies sometimes improvise during development. We often think of our anatomy as this perfectly fixed blueprint, but sometimes it takes some really unexpected and fascinating detours. And we're not talking about defects here. Think of them more like unique variations, each with its own incredible story.
So what actually happens when our internal architecture deviates from those textbook diagrams? We're going to look at two amazing examples, both in the urinary system, that show us exactly how our bodies can adapt and, in turn, how medicine responds. It's a journey into development, a little bit of plumbing, and some really clever surgical solutions. All right, first up, let's talk about the ureter seal. And really, the best way to wrap your head around this is to think of it like a plumbing problem, a very specific kind of blockage at a super crucial junction in our urinary tract. Okay, this analogy is perfect. Imagine the ureter. That's the tube that carries urine from your kidney down to the bladder. Now picture it ending in this little balloon-like swelling, right at the spot where it connects to the bladder. This tiny water balloon can actually obstruct the flow of urine, causing everything to back up. Not good.
And here's the more official medical definition for you. A cystic swelling is just the fancy way of saying a fluid-filled sac, our little water balloon. This blockage is the main problem that has to be dealt with because, as you can imagine, backed up urine can lead to some pretty serious issues down the line.
Now, you might think the first step is to go in and fix the physical blockage, right? Well, not exactly. Before doctors can even think about that, they have to deal with the most immediate risk. Stagnant, backed up urine is basically a perfect breeding ground for bacteria, and that can lead to some really nasty infections. That's why the very first line of defense is to get the patient on antibiotics right away. Okay, so once that infection risk is under control, the next logical step is to deal with the water balloon itself. But the approach here isn't one size fits all, not even close. It actually changes dramatically depending on one key factor, the patient's age. Let's start by looking at how doctors handle this in infants and children.
So for kids, the approach is super personalized, and it all depends on how healthy the kidney is. For example, see that word reflux? That just means urine is flowing backward, which is definitely not what you want. So if the kidney is working well and there's no reflux, doctors can do a pretty simple procedure to basically pop the balloon. But if a part of the kidney is already damaged, well, that requires a more complex surgery to remove that section. And in yet another scenario with reflux, surgeons might have to remove the ureter seal completely and carefully reattach the ureter to the bladder. It's all about tailoring the solution to the exact problem.
Now, compare all that complexity to how it's handled in adults. In most cases, it's a lot more straightforward. The go-to treatment is to simply go in with a scope and decompress or puncture the ureter seal. It's a way less invasive approach that often solves the problem without needing all those complex reconstructions we sometimes see in kids.
All right, let's shift gears. We're going from a blockage to a fusion. Our second case is the horseshoe kidney. And this isn't really a story about a problem, but more of a fascinating tale about a really unusual developmental journey.
I mean, the name really says it all, doesn't it? Instead of two separate bean-shaped kidneys, a person with this has a single U-shaped kidney structure. This happens when the bottom tips of the two developing kidneys fuse together while an embryo is still developing. And what's wild is that many people with this condition are totally asymptomatic. They might not even know they have it. In that connecting bridge of tissue, it has a specific name, the isthmus. And this isthmus isn't always the same. Sometimes it's made of simple, fibrous connective tissue. But in other cases, it can be made of actual functioning kidney tissue, making that bridge a working part of the organ itself.
So how in the world does this happen? The story of the horseshoe kidney is really a tale of migration and a single critical roadblock. It's just a beautiful example of how incredibly dynamic our development truly is. Let's walk through this incredible journey. First off, our kidneys don't start where you think they are. They actually begin developing way down in the pelvis. And because they're so close together, a simple flexion of the developing spine can push their bottom ends together and boom, they fuse. Then, this new U-shaped kidney starts its big trip upward, trying to get to its final spot in the abdomen. But then it hits a snag. The isthmus, that bridge, literally gets hooked on a major blood vessel, the inferior mesenteric artery, which stops its journey short.
And this is the direct result. Because its journey was cut short, the horseshoe kidney ends up sitting lower in the abdomen than two separate kidneys normally would. That connecting isthmus usually ends up right around the level of the third or fourth lumbar vertebra. It's like a permanent landmark of its unique developmental path.